Hey guys, thanks for joining me. This week's case is about a woman with a chief complaint of headaches, abdominal pain, and visual symptoms in the postpartum period. Now, she was a 38-year-old female who presented several days after giving delivery to her first child. The pregnancy was uncomplicated except for minimal blood pressure elevations in the third trimester, and she actually had a very normal spontaneous vaginal delivery and a normal postpartum period. Now, she came to the ED because of complaints of severe headaches, along with visual symptoms, flashing lights, and abdominal pain. And on arrival, she was hypertensive to about 180 or 115, and the rest of her vital signs were all right. Now, when you take a look at a case like this, we are all thinking about preeclampsia. Now, the questions we'll talk about today are the ECG, how can it present? And then next week in part two, we'll talk about the management strategy. How do you actually go about taking care of someone like this? And what are the most feared complications? All right, so here's the 12-lead ECG. This was done right away. She was put on a monitor and we saw this ECG. Take a look at it, hit the pause button now, as a matter of fact, and see if you can come up with an interpretation, and we'll continue. So the obvious ECG findings are that the QRS is wide. It's greater than 120 milliseconds rather. It's not tachycardic. There's an RSR prime pattern. Sometimes you see a QR pattern, but this is an RSR prime pattern seen best in lead V1, along with slurred S waves in lead V6 and in the limb leads 1 and AVL. Now, there's a slurred wave. You can see this right here. The slurred S wave is quite pronounced. And here are the, again, slurred S waves in lead 1 and in AVL. All right, so this was a right bundle branch block pattern, fairly straightforward. Let's drill down on lead V1. That is the money lead for something like this. And if you look at it, you can see an R wave, a small R wave, followed by an S wave, and then a bigger second R wave, we call it R prime, so therefore it gets its name as an RSR prime pattern. And if you take a look down here, there's a very appropriate T wave discordance, and that is important, as we'll see later on. So when I see something like this in lead V1, my next move is to do a V6 cross-check, because that's what confirms this pattern. And if you look at V6, V6 actually has a QRS that is wide with an R wave and then a very wide, deep, and broad slurred S wave. And that is what I think clinches it for a right bundle branch block pattern. All right, and remember, a newly upright T wave in lead V1, right, when it's taller, especially taller than in V6, that is very concerning for things like ischemia. So never, just make that into nothing. Always pay attention to it. So causes, what are some causes? Well, I think of about 10 or so. Certainly we see this in the normal variant, especially in younger people. Chest wall trauma can give you a right bundle branch block pattern. Myocardial ischemia, there's a lot to be said about that, and a lot of literature coming out about that. Acute PE can certainly give it the same pattern. Right ventricular hypertrophy and severe uncontrolled hypertension, and that is what she had, this woman. And let's not forget about things like Lev's disease. We've talked about this in the past. Congenital problems, especially in kids, cardiomyopathies, and myocarditis. So a wide range of causes for right bundle branch block pattern. But in this case, severe hypertension can certainly give you the same pattern because of the increased RV pressures putting pressure on the right bundle itself. So anatomically, when you look at the conduction system, there's the remember, there's the left and right bundles are there. The left bundle branch is actually, it's bigger, thicker, more robust, and it is therefore responsible for depolarizing the septum. And when you have something like a right bundle branch block that is down completely, the depolarized septum now goes on to activate the right ventricle, causing you to have this partial depolarization of the right ventricle itself. Now, in the meantime, what's happening is that the left bundle conducts electricity to the LV normally, And then there's this very slow myocyte to myocyte conduction from left to right, then finally depolarizing the RV, giving rise to that second wave, the big R wave that follows. Okay, so at the same time, if you look at V6, what's happening there is, well, right here, you have a normal conduction of impulses down the left bundle, and then what you have here is a very slow myocyte to myocyte conduction of the heart from LV to RV, and lead V6 sees this as impulses moving away from it. Therefore, it draws out this broad, deep S-wave pattern. So part 2 coming up next week is going to be more on the diagnostic criteria, management, and one of the most dreaded syndromes called HELP syndrome, a complication to preeclampsia. That's it for this week, folks. This is Sush from Master Your Medics. Take care.